Good afternoon, everyone, and thank you for joining us today. My name is Matthew Hayes, and I'm the Medical Director of the Wessex Cancer Alliance. We've been invited to describe the approach we've been developing in Wessex to embed primary care in all aspects of our work programme, which we really believe to be crucial in our endeavours to deliver the cancer priorities of the NHS long-term plan. I'm delighted to be joined by Drs. Nigel Watson and Sania Ward, who are our Cancer Alliance primary care leads. And they will describe the detail of our approach and the development of our primary care strategy. We'll aim to answer any questions you pose in the chat function as we go along. So please feel free to use this as you wish. Next slide, please. The Anglo-Saxon kingdom of Wessex sat across a great swathe of southern England and was ruled over, of course, at the height of its power by King Alfred the Great from his capital in Winchester. Next slide, please. In the 21st century, Wessex is a little smaller in size and constitutes the two ICSs of Dorset and Hampshire and the Isle of Wight, representing a population of around 3 million people. Our geography encompasses a diverse cross-section of society, including large conurbations, significant rurality, and an island population. Next slide, please. It's pretty clear that 2021 has brought with it a number of challenges for all those working to improve outcomes and experience for cancer patients, and our alliance is no exception. We are aiming, of course, towards detecting 75% of cancers at stage 1 and 2 by 2028. We have challenges around workforce and the configuration of services. There is ongoing inequity of access to services which have been exacerbated by the COVID pandemic across our pathways. We're having to come to terms with evolution in commissioning structures, moving from clinical commissioning groups through STPs and ICSs, and how specialised commissioning fits into this. For Wessex, we also sit across the south-east-south-west boundaries, which gives us a bit of a regional challenge. And importantly, we have to develop a better understanding of how primary care networks will synergise with ICSs and ICPs as they evolve. And of course, the pre-existing pressure on cancer waiting times performance has been exacerbated by COVID, although I'm pleased to say that our performance in Wessex is currently good, where in March we met the 2-week wait standard and the 62-day standard was at 83%, which, although not quite where we wished it to be, was the best performing alliance at that point. Next slide, please. So, of course, most pathway entry points come from primary care. Most pathway exit points lead into primary care. And primary care sits in relevance, of course, across the totality of all of our pathways. If we're to be successful, there is an essential need for us to place an emphasis on earlier detection and faster diagnosis. We know, of course, that the care of patients with long-term conditions sits predominantly in community care and is often nurse-led. We believe that the needs of our communities are best understood by the communities themselves. And of course, primary care are well placed to articulate this. PCNs and ICSs are early in their evolution, so we believe there is an opportunity here for alliances to work effectively in that arena. So we decided that there was a need for us to develop a primary care strategy with clearly defined local leadership and a mandate that applied across the whole of our alliance geography. So we were fortunate to find Drs. Nigel Watson and Sania Ward, who are our Cancer Alliance clinical leads for primary care, sitting in Hampshire and the Isle of Wight and Dorset respectively. And I'm going to hand over to them to give you the detail of our approach.
Thank you, Matt. When you look at cancer from a GP's point of view, you can look at the figures which show that approximately 300,000 people will present every year with a new diagnosis of cancer. There's 1 million consultations a day in general practice, so over 300 million per year. So when you sit as a GP, you'd expect to see probably between 8 or 9 new cancers a year will present to you. And of course, it's not just a presentation. We look after people on an ongoing basis. So you'd expect to have somewhere between 20 and 30 patients who've got cancer who you have a responsibility for. And over time, you can see that the last 40 years, the survival rate for cancer has doubled. But that means that the number of people sitting in primary care has increased, the number of people with cancer, which is also that important role about living well with and beyond your cancer. So there's a really critical role for the primary care team, not just GPs, to be looking after these patients. If you look at the National Cancer Diagnostic Audit back in 2014, then the vast majority, nearly 75% of patients presented at first with their GP, and about the similar number were referred after 1 or 2 consultations. It often causes some distress to GPs when you see reports in the media that somebody saw a GP 8 or 9 times before they were referred, without giving the context of people present with an undifferentiated number of symptoms, and therefore sometimes it is really obvious that the risk is the person might have cancer, but actually more often than not the symptoms don't point immediately to cancer, which is why you need to do investigations and look at a more longitudinal history. And when you look at safety netting, which is becoming increasingly important, that audit suggested that only just under half the people had safety netting advice in their records, although I'm sure the vast majority of GPs, if they present with various symptoms, will either ask to see the person again or will say, if this doesn't get better, please come back and see me. So when you look back over history and look at many pathways, and cancer services is no different to many of the others, often it starts and finishes in the hospital. And as Matt has said earlier, actually with cancer, the agenda and the pathway often starts with primary care and finishes with primary care. We provide cradle to grave care. So when we're looking at pathways, really important that the general practice aspect of that is not only part of it, but actually is integrated, because we don't just see a person start with a GP, finish, go into hospital, and when they finish, come back. People during their cancer treatment, which may be surgery, radiotherapy, chemotherapy, will often have contact with their GP and often look for emotional, psychological, or physical support, or other conditions they've got. So it is really important that general practice is not forgotten in this. And that was one of the reasons through the Wessex Cancer Alliance we decided to develop a primary care strategy to see what is it that we could do in primary care to improve the care of patients and also improve the outcome. So we asked the question, why do we need a primary care strategy? Well, that's about providing some primary care leadership, making sure we've got a voice in when we're looking at things. What's primary care's view of this? How can we support the earlier diagnosis, the faster diagnosis? If we're going to have community-based diagnostic services, how can we make sure that meets our community needs, and also how, as general practice, we can work with it? And how do we support not only practices, but clinicians working in practices, whether they be nurses, GPs, and now the wider primary care team? And actually, how do we coordinate that? General practice is fantastic at rapid development, change when it's needed, but we actually need a more consistent voice. And all too often in the past, general practice has not really had an influence on how the system delivers services. It has to adapt to what we're told to do. So we want to be in there and influencing. And as the whole of medicine changes so fast, there is a huge role in education, in keeping people up to date with what's relevant to GPs. I don't need to know what the latest chemotherapy agent is used in the hospital, but what I do need to know is, are the survival rates improving? What is it that we can do in earlier detection? What is it that, what are we missing in terms of regular symptoms that might present that we're not aware of? And how do we share and that information across more than just the GP, the practice nurses, and actually now with things like social prescribers and healthcare facilitators, all of that play an important role, not least our receptionists, who are often the front door into our practices. So we started to produce a strategy, and with Matt's leadership, got support from the Cancer Alliance board. So where are we now? Cancer is a really important part of general practice, not least because if you look at the two major causes of mortality are cancer and cardiovascular disease. So cancer has, as we've been told, has had an impact on where people are diagnosed and how quickly because of COVID. So the GP contract at the moment is focusing on the quality and outcome framework, that we've had a cancer register for a long time. But actually what we're now looking at is the cancer care review. How do we review patients, not 3 months after they're diagnosed with their cancer, but also 12 months down the line? Have they recovered? What are their needs? What are the ongoing management, whether that be in general practice or in hospital, and what impact has that had on the wider family? So the whole lot of things that you could do within a cancer care review. Also, when you look at one of the major preventable determinants are smoking, and that's a major part of QOF, not only recording people's smoking status, but also ensuring that there is really good quality smoking cessation advice that's easily accessible. Cervical screening, again, looking at the percentage uptake and the incentivization of looking further than just sending 3 letters, inviting people in. How do we get to those communities where the uptake is lower than others? And finally, looking at the quality improvement bit of QOF, which the quality and outcome framework, which is looking at the earlier diagnosis of cancer, because clearly the earlier we can diagnose it, the greater the chance of long-term survival. And as general practice has evolved and the newly established primary care networks, groups of practices working together in the community, part of the enhanced service for primary care networks is incentivizing the networks working together, sharing learning, looking at improving outcomes. So looking at use of the 2-week cancer weights, looking at how you identify the people who present as an emergency. Could we have picked something up earlier? That cycle of continuous improvement. And also then peer review meetings. There is so much we can learn from each other and from our own experiences. So clearly, when you look at the strategy, we're looking at prevention, early diagnosis, faster diagnosis, personalized care. So in prevention, we're looking at things like, could we do very brief interventions at services that are provided by nurses, healthcare assistants? That interaction with the patient, you only need a sentence or 2 sentences just to remind people of things that might be relevant to them that relate to cancer. Using different techniques to use that innovation that occurs, different ways of just the traditional talking to the patient and saying you shouldn't do this or you shouldn't do that, giving people information through different media. All those things will target individuals in terms of both the information you give them, but also clearly the age they are or the risk you might think they are. So, if you see people of 60 who are male, then that might be a good opportunity to raise, have you got any symptoms which might be related to prostate cancer, for example? There are different ways of doing that. Also, now it is no longer just the GP in a surgery talking to a patient. We've got nurses, we've got pharmacists, we've got paramedics, first point of contact, musculoskeletal, we've got social prescribers. So there's a whole range of people that are interacting with patients, working as a team. So it's important in terms of the prevention agenda that we are all mindful of cancer as a diagnosis, but also how we pick this up and how we prevent people from getting it, using that brief bit of advice that just sows the seed into people's minds. In terms of earlier diagnosis, clearly one of the key bits is about screening, whether that's cervical screening, bowel screening, breast screening. And there are things we can do at a practice level and a PCN level. The breast screening unit comes to town. So why are we not putting adverts in the practice newsletters on the practice website, putting it in the screens in the surgery? Cervical screening, you look across practices and the uptake in the more affluent areas is generally higher and the more socially deprived areas is much lower. So using the same way of trying to invite people in both those groups clearly is not going to get the high uptake we need. So where we've got lower uptakes, what could we do to improve the uptake? Is it about doing things in different languages, using community leaders? And actually, is it about providing better access? So are we doing cervical screening, for example, in our extended hours appointments at weekends? Are we offering people a better opportunity to access our services? Also to do with education and early detection, we know that medicine and clinical work changes quickly, and to keep up to date with that, we need to provide some bespoke education which is focused on the needs of the individual and also of the primary care team. And that education is provided by a broad number of providers, CRUK, the College, Macmillan, the Cancer Alliance. There are independent providers, Gateway C, etc. So it's also about signposting people to where they can find the information, and also doing it in a different way. So, for example, we're looking at audio podcasts, which are downloadable and you can do while you're on the move. You can listen to things in small chunks, which are much more accessible. And also, when you look at innovation and new ways of detecting cancer or new ways of working, those are all things which we need to be able to share and try out and use. Faster diagnosis, if you look at how we're going to get the pathway working, one of the frustrations about being a GP, we often see barriers in pathways. So some of the role that Sanya and I are playing is to remove those barriers. When we sit in a surgery as a GP, this is the barrier that we need to remove to actually get the patient to the place they need faster and quicker and without those impediments. Also looking at new developments, whether they be in cancer treatment, in diagnostic tests, in the way we use those, interpret them, sharing that information to make sure we make the best use of it. And personalized care, looking at the needs of the patients. We work really well with some of the patient groups and the people who have an understanding of cancer from a patient point of view rather than just a clinical point of view. And then we can tailor the care that's needed around the individual. Actually, as GPs, we're quite used to doing that, treating people as an individual and looking at what their needs are, because their needs will be very different. If we then look at how we do some of that, and this is about engaging with patients, and as a group of clinicians working in the alliance, it's about pulling out some of those key messages and sharing that with our colleagues, about working in a system and utilizing ways that are often done elsewhere. We're not always innovating new ideas, but thinking of other ways that we can help and support individuals. I talked a bit about education and also about the workforce, the broadening workforce, and making sure that we provide and support information to all of those. I've talked about patient engagement, and we've developed a website called Wessex Cancer Matters, which provides lots of information both in written form and in video form for the patients to access. Also, in terms of the system, it's really important that some of these meetings, that there are GPs present there who can participate in that debate about how do we get to patients earlier, particularly as the vast majority of them will present to GPs first and then we look to where they go on afterwards. The faster diagnosis, it's picking up bits and looking at what is it that why do patients not come with symptoms that we think are pretty obvious, and how do we work with patient groups to raise the profile without raising anxiety, and this communication between different providers. Often patients will say in the NHS we work as silos, your GP, then you can go into the hospital, then you go to community, you might go to a hospice, you might come to general practice, and it's not always joined up. So we're working really hard to try and join that up in a more cohesive way. And again, looking through the personalised care agenda, that as primary care leads and working with others, we're looking to try and look at every single bit of the patient experience, the system working, the education, the workforce, to support all that to make it a better service with better patient experience. I would like to give great credit to our Cancer Alliance locally, who listened to what we had to say. We were pushing on an open door, and they've invested significantly in the engagement with primary care. In my previous role as Chief Executive of an LMC, we worked really closely with the Cancer Alliance to look at how we represented practices and GPs. We also have engaged with the Macmillan Cancer GPs, and they now work with us in the Wessex Cancer Alliance. We work closely with Cancer Research UK and also with the CCGs. We're there saying, you're commissioning services, but this is how we think it should be, could be better provided, and we want to work collaboratively with you. And the Cancer Alliance have then put resources in to bring GPs on board to work on the whole cancer strategy, but particularly looking at the primary care aspects of it. And through Sanya and my roles, then what we try and do is work collaboratively with the GPs. We've got the strategy, and now we're in the advanced stages of developing an implementation plan, picking bits of the strategy off and making sure that we can back them up with implementation for each of those areas, which hopefully will then build to a delivery which will then give us measurable outcomes. And also, just quickly, this is more than just doctors. As I've said, we're doing, for example, a pilot which is called Cancer Nursing Across Boundaries, where we recognise that people with cancer need more than just hospital-based care and the superb work done by the specialist cancer nurses. Now, some of those are now coming out in a pilot, working in practices 4 days a week, supporting practice nurses and upskilling them, but also working with GPs, pharmacists, and other people working in the primary care team. And hopefully, as an example of this will show how we can deliver care that's more effective, give better outcomes, but also breaks down those historic barriers between primary and secondary care. And this slide isn't terribly easy to see on this, but if you look at the whole slide deck, you'll see there are a number of initiatives within this which then allow the nursing team to work with the specialist cancer nurses to look at how we can upskill people, better educate people, and therefore get better outcomes. So to implement the strategy, this is largely being led by the primary care people. So that's not just Sanya and I, but the other GPs. And we're looking at how we look in each of those areas very distinctly. Prevention, what could we do that's different? Earlier diagnosis, doing things like going and doing practice visits, which Sanya, I think, is going to talk a bit more about, the screening rates. Also, the rapid diagnostic service, which again, Sanya is going to talk about in a minute. Faster diagnosis, can we sit on these site-specific pathways and give a GP's perspective of what could be improved on there? And again, with personalised care, really struck home to me this saying, which is what matters to me rather than what is the matter with me. Because patients, particularly with cancer, they're no two are the same. To some, cure is the most important thing. Others is the quality of life. The things that you can do to help them are vastly different. Just want to quickly give you one example of how we've pulled some of this together. So we were looking as a system at COVID, and if you're a smoker, your increased risk of COVID. So we started a campaign called Quick for COVID, and we were working with our public health teams and CCGs, looking at sending text messages to all the smokers that we identified working with general practice and giving them advice about seeking smoking cessation services. And we worked with the councils to make sure those services were ready, available, and people could access them. We then talked about, actually the other concern is people with coughs and potentially with COVID, particularly if the cough's unresolved, might actually be missing lung cancers. So we then worked as an alliance across the CCGs with the LMC and decided what we would then do is link that message with some education about lung cancer. We're doing a screening, looking at people with in Dorset, which again Sanya will talk about trying to detect lung cancer with people with certain symptoms. So doing some lung screening. We're looking at lung health checks as one of the pilot studies with low radiation CT scans for people who are at risk. We then thought we could do this to educate not only GPs but the general public. So we worked with the BBC. We did a couple of short pieces on the news programs about COVID, about people presenting with cough, about lung cancer, and about the treatments and the things we were using to try and detect lung cancer, but also about the prevention agenda. We then did a webinar with GPs looking at the background to lung cancer, the update in treatment, the programs that were going to help detect early lung cancer and those at most risk. And that was hugely successful. And actually, we had loads of people attending the webinar at the time and afterwards. Also, the messaging that went out on the SMS, we got a significant number of those smokers who then attended smoking cessation. And finally, putting something out on the news program does have an impact. It's much harder to measure. So it's just one example of pulling a number of threads together, which as GPs and primary care leads, we were able to do across the system. Potential pitfalls. Well, obviously, working in general practice, we've got a huge number of practices in Wessex. So we've got the independent units, and that means that communication can be difficult. Also, we're now developing a much more multi-professional workforce. So it's not just GPs. How do we engage with the practice nurses and others who cancer has never really been the top of their agenda, but we don't want to make it higher up in their agenda. So we're working hard on that. And also, screening is run by the NHS England Public Health people. So engaging with them to say, well, actually, if we're going to increase screening, this is what we can do to help you. So working across stakeholders and aligning the agendas. But also we recognise, as we're coming out of COVID, hopefully, the workload in all areas. So whether that's hospital, community, general practice is significant. So what we don't want to do is have a great strategy and then say, right, we would like you to do all this work. This will be great for patients, but please get on with it. And therefore, there can be conflicting priorities, both within general practice, but also within other services, where if we increase the demand for services and we haven't got the capacity to meet them, that causes a problem. And how do you incentivize that? So the strategy's there, the implementation is being developed. I think it's a really exciting time for the Cancer Alliance. And I'd like to hand over to Dr. Sonia Ward to take us further from her experience. Sonia, over to you.
Thank you, Nigel. So I'm just going to talk you through some of the practical examples of the work that we've done in Dorset, contributing towards the strategy that Nigel spoke about. So the first element really was engaging with practices and primary care networks through a series of visits. So we approached the PCN clinical directors who are new in post and just really starting to sort of bring groups of practices together into networks to work towards shared goals. So we approached them via email and by presenting in their clinical directors meeting with an offer to visit them virtually and discuss the requirements of the primary care network DARES and QOF in the national contract that Nigel spoke about, and crucially actually to discuss and share their practice level data. And that was really the hook of interest that meant that almost all of our networks took up the offer of a virtual visit. So talking about the data, there's obviously access to the PHE fingertips data, but that's not always the most live and up-to-date data. You're often dealing with data that's sort of 18 months to 2 years out of date. So what we did in Dorset was to work with the local provider trusts to capture data on the number of 2-week wait referrals being made, the conversion rate to cancer, which could also be broken down by tumour site, stage at diagnosis, and again represented by tumour site as well, and the number of diagnoses made via an emergency presentation or admission. And we were able to break that data down so it was available by practice, but also by primary care network. We used some of the screening uptake data that was available via fingertips, but we also used the CR UK screening predictor uptake tool and shared some of that data with the practices. And this was produced initially as a data pack. And these were actually a really good tool in terms of engaging the practices and the networks and stimulating conversation about how they might want to target some of their improvement plans and improve early detection and diagnosis. GPs are always interested in how their neighbour practice is doing or the network down the road and how they compare. So being able to show the data in that way was a really useful hook and tool into getting conversations going about local improvement plans and how earlier detection might be achieved. That data was initially as a pack, but we've actually now gone on to develop that as a primary care cancer dashboard, showing all the data that I've talked about and available by practice and by PCN. And GPs and the primary care network clinical leads across Dorset will have access to that as a cancer dashboard to look at pretty much real-time data on their patients. The visits were done by Cancer Alliance primary care leads, so sort of my role or Nigel's equivalent role, and also using our Cancer Alliance Macmillan GPs and our CRUK facilitators. Next slide, please. In addition to that, we worked with the CCG in Dorset to commit to fund some local enhanced services. And this was really to enhance the work that GPs were being encouraged to do through the national contract that Nigel spoke about, but to really pick out some areas of early detection that we felt that it would really be of benefit for practices to work towards. We asked them to sign up to an early detection of cancer LES, and this required practices within networks to do audits on areas such as late stage presentations and emergency presentations, so reviewing cases that presented late or at emergency presentation. We also asked them to audit the quality and the information that was provided to patients at the time of their cancer referral. There is a requirement for clinicians within the network to undertake the Gateway C education module on improving your cancer referral. And also there is the requirement to appoint a cancer lead or champion within the primary care network. And actually appointing the encouragement of appointing that cancer lead person within primary care networks has proved really effective, both as a contact point for us at the Cancer Alliance when we're wanting to share information, but for also coordinating their improvement plans on prevention and early detection within their network. The other area of a local enhanced service that we focused on was around lung cancer. So this was a clinical priority even in pre-COVID because of a real desire to try and improve outcomes and early detection. But obviously it became obvious throughout the COVID pandemic that we saw decreasing referrals for lung cancer, and also there was this sort of concern and confusion around chronic cough, as Nigel spoke about earlier. So we funded some work within our primary care networks that asked practices to search through their records, identifying people who'd smoked or were ex-smokers and had had a finding of a raised platelet count. And then the invitation was for those patients to attend for chest x-ray or for clinical review of any concerning symptoms. So we're still awaiting the sort of final reporting of that service, but the feedback that we've had from primary care is that that's actually been quite effective in terms of changing practice, and particularly raising the sort of educational point and profile of being suspicious of cancer when you come across a patient with an unexplained raised platelet count. Next slide, please. So some of the culmination of this work over the last year in Dorset was our Early Detection of Cancer conference. So this was attended by the cancer leads or champions within the networks, and also the invitation was to the clinical directors. It was held obviously over Microsoft Teams this time, and what it did is we provided sort of an hour of educational and organisational updates for the clinicians attending, so things such as sort of talking about fit and new pathways and services for them to be aware of and then subsequently share within their networks. But the second hour of the conference was structured as peer discussion, and what we wanted to do was try and cover some key topics on the cancer agenda and learn more about what's happening in different practices and share that learning across the patch. So we had discussions on reducing inequalities in screening uptake and cancer referral. We heard about some excellent work that was being done with teams looking after homeless people, for example, and linking with drug and alcohol services, who are obviously traditionally low in numbers to uptake invitations of screening. We talked about the importance of safety netting and how different practices and networks have different systems in place for safety netting, and we shared some best practice around that. We talked about factors that contribute towards emergency cancer presentations and work that can be done and learning that can be shared to reduce those emergency presentations. And we also discussed communication. So that's both between primary and secondary care and how that can be improved, and also actually crucially how practices communicate with their patients. There's increased use now of social media and also text messaging, and how we can just make sure that we optimise those opportunities to communicate with our patients, to promote screening and to encourage patients with worrying symptoms to come forward. So the sort of culmination of those discussions was a shared learning points and action plan, which has then been shared with those cancer leads across Dorset. Next slide, please. The other example of working with primary care that I wanted to share with you was the work on our Rapid Investigation Service, so formerly the Rapid Diagnostic Service and part of the RDC programme of work. So when we started conversations with primary care about this sort of service for patients with non-specific symptoms, there was immediate enthusiasm within primary care for this. Many GPs could identify the types of patients that we were talking about here and shared the frustrations of how difficult it can be to get these patients investigated and referred in an appropriate pathway and in a timely way as well. So our Rapid Investigation Service in Wessex is a virtual service for patients with non-site specific symptoms who don't fulfil any of the other tumour site 2-week wait pathways, and it was launched in June 2020. We did a lot of primary care engagement in the design, recognised the importance that this was a service that needed to work really well for primary care referring into, but also for this sort of output and outcome when patients were discharged from the service. So I, along with another primary care colleague, led a task and finish group to develop the referral and triage criteria for the service. We initially launched, as I said, in June 2020 as a pilot with just one PCN, and then that was quite quickly scaled up to 3 primary care network areas. It's now, as of the late autumn, live across the whole of the Wessex region. And what's really important is that there's continued engagement with primary care to refine the service, to educate about the referral criteria, and there's strong primary care representation on the clinical reference group for the service, but also in project groups as we start to think about future pathways that might be suitable for the RIS. So that was some examples of some of the sort of specific projects we've been working on in Dorset and in Wessex. So I'm going to hand back to Matt now to summarise what we've been talking about.
Thank you, Sonia. So as we've said, primary care clearly is absolutely central to the delivery of the long-term plan when it comes to our ambitions for cancer. Some specific recommendations I think would need to include the need to ensure clearly defined and resourced primary care leadership across the system. We were fortunate enough to have a very functional LMC with whom we worked in the genesis of this piece of work. Really important thereafter to develop a primary care team with a clearly defined strategy for delivery. And I believe strongly that that needs to be directly responsible to the Cancer Alliance board. There can be some advantage in seeking third sector support in terms of ensuring that. The investment in communications is critical. It's got to be relevant to primary care, and it must include all digital options. So we've developed 2 websites. We've got a very active Twitter feed, and we have regularly emailed updates as well for those who still like to engage in that way. There is a real need to assure mutual benefit. This needs to work for primary care as well as for the Alliance and its purpose. And you've heard about using the DES education and training webinars and CPD accreditation to ensure that it rings everybody's bells. And a tailored approach to in-reach into practices is attractive and works well, using practice and PCN level data and talking about, for example, things like emergency presentations. So take-home messages, simple really. Patients get ill generally out of hospital rather than in hospital, and that's generally where they live and work. Healthcare inequalities within communities are often best understood both by and in primary care settings. And primary care interactions predominate throughout the cancer pathways and cross all of the long-term plan priorities. And if we really are meaningful about our need to develop the early detection agenda such that we get to that 75% stage 1 and 2 by 2028, then of course we're not going to do that without general practice. Thank you very much for listening. We'd be delighted to answer any of your questions, as I said earlier, and if you would like to make contact with us directly, please feel free to either by coming through to our Cancer Alliance website or by email. Thank you all for listening.